our big man, Professor Debraj SHOME, as the chairperson of this mission. Of course, everyone knows that Professor Debraj SHOME, is being a global pioneer of new techniques and cosmetic surgery. So we are looking forward to have a great section. This title should be, Why Should You Learn Facial Cosmetic Surgery and How to Get Trained. And
Thank you so much, Masashi, and thanks to all the friends who are on the panel to be here, and thanks to the audience as well for bearing with us for the past 4 days and still being here early in the morning. My name is Debraj SHOME, and a long time ago when I decided to get into ophthalmology, because I saw that as a route to get into facial cosmetic surgery, a lot of people wondered why ophthalmology should be the residency route to get into facial cosmetic surgery. But the truth of the matter is, when you train in facial plastics and facial cosmetic surgery, majority of the folks who are doing facial plastics and facial cosmetic surgery today come from either an ophthalmology or ENT background, at least in the Western world. So I was a very odd ophthalmology resident who never wanted to do cataract surgery. I was very certain I was not interested in cataracts. I would never do cataracts. And for me, my ophthalmology residency was a way to get into facial cosmetic surgery. And today, approximately about 12 to 15 years later, when I see that facial cosmetic surgery is one of the instruction courses at AIOS, then some of what I felt feels validated and vindicated at this moment in time. It's very important to understand that when I treat the face, the most important parts of the face or the most difficult parts to treat are all periocular. And given the fact that ophthalmologists have had experience in dealing with with microsurgery, it's only fair that ophthalmologists play a major role in facial plastic surgery as it moves onwards and upwards. Our specialties of facial aesthetics and facial cosmetic surgery have not been around for that long. If you think about it, it's only in 1989 that Allergan's Botox received US FDA approval. And obviously, all of us are very proud and know that the use of Botox in facial aesthetics has actually dermatology as well as ophthalmology backgrounds, because Gene Carruthers, one of my mentors, is an oculofacial plastic surgeon based out of Vancouver in British Columbia. Now, we started using, I'm not going to play this video because there's no point, this video was actually on hemifacial spasm. That's how we started treating things. And then when you saw the lines disappeared, by serendipity, you discovered that it might be a good time to use the Botox for facial lines. And fillers actually came into the market in the early 2000s. So fillers started entering India only around 2005 and 6, 7 maybe. So as a result of which, and that too, they were very low G prime fillers at that moment in time. So actually, it's not even been 2 decades since fillers came in, which is why this particular specialty of the face is still so undecided. Everyone thinks they own it, but no one really understands it, and no residency program really trains you in it. Now, if you want to see patients like this, so if you saw a patient like this, yes, she has under-eye dark circles, she's got a little bit of aging and all of that, but just concentrating on the typical oculoplastic treatments of trying to treat her periocularly would not give you results like this. And that is why learning how to treat patients holistically becomes important. No fracture, no treatment actually looks at residential fault lines. They occur all over the face, and therefore you need to learn to treat patients, or we need to learn to treat patients in a manner which makes it holistically possible to generate results such as these, or these. Now, how did it all happen? I think the first and the foremost important thing is to figure out what you really want to do in life. In my opinion, if you want to get into facial cosmetic surgery, possibly doing traditional cataract surgery may actually be a deterrent to you. If you are into cataract surgery and you're into refractive surgery, then there's already so much work for you to do. You may not necessarily want to get into oculoplastics and facial cosmetic surgery. I was very lucky that out of my 4 fellowships, my first fellowship preceptor, Dr. Santosh Honavar, who's also the secretary of AIOS at this moment in time, did not allow us to do any cataracts. That's one of the reasons that I trained under him. I didn't want to do any cataracts. And as his only fellow at that moment, a very busy practice at LV Prasad Eye Institute, I was so well versed in oculoplastic surgery by the time I finished my fellowship. I was literally thinking of doing DCRs with my leg, no jokes. Now, at the end of that, you also need to figure out how to get there in terms of skill, right? You get into ophthalmology, you get into oculofacial plastic surgery, but how do you expand your repertoire? And that's what all the talks in this are all about. My friend Tanuj Nakra will join in from the US as well, and he'll tell you how to get into rhinoplasty and so on and so forth. So exploring legal frameworks and pushing the envelope in the Asian region becomes very important. Now, the first part of knowing what you want is knowing what you don't want. And the first part of realizing this is you cannot be all things to all people. You can't be good at everything you do. So you need to be very clear what you want to do. Now, even in oculoplastics, at least the way it's developing in India, we are all super specialized in different things. I mean, my colleagues, Milind Naik or Mohammad Javed Ali, may be a completely different type of oculofacial plastic surgeon. I'm a totally different type of oculofacial plastic surgeon. So even in our subspecialties, the amount of super specialization and the depth of knowledge that each one of us is getting into is probably making things more and more interesting for patients. I cannot hope to treat retinoblastoma the same way that a LV Prasad Eye Institute or a Center for Sight does. And that's what I mean by saying you can't be all things to all people. And above all, to thy own self be true. What does that mean? We need to be clear what we are good at and do what we are good at and refer other things. Now, if you look at my medical journey, I came in from Grant Medical College, which was one of the topmost medical colleges in India. Went to Shankar Netralaya, which is probably the holy grail for ophthalmology residency. Did my first fellowship at LV Prasad Eye Institute. Went to the University of Utah to train under Dr. Richard L. Anderson under the FICO Fellowship for facial plastic surgery. Worked at Tata Memorial Hospital. Got an MBA from an Ivy League B school in the US. Established the aesthetic clinics, got a maxillofacial surgery fellowship from the AOCMF, and so on and so forth, until I finally got American board certified in facial cosmetic surgery. This pathway is something that I've explored. And so I'm going to be talking about how you can explore similar sort of pathways in order to make sure that legally you are well within your rights to do whatever you do. Now, let's look at how things are changing. The ICO curriculum for ophthalmology, very interestingly, is now beginning to talk about all sorts of flaps. It's also beginning to talk about endoscopy for treating DCR. It's beginning to talk about the head and neck in relation to the orbits and the adnexa. So it's very clear. One of our other speakers who's going to speak after me is Dr. Bob Goldberg. And he's been an icon all over. And he keeps saying that oculofacial plastic surgeons should own the entire face right up till the anterior cranial fossa. And that's basically what we are trying to do, right? Each one of us in our own way. Interestingly enough, when you look at the ASOPRIS, the American Society of Ophthalmic Plastic and Reconstructive Surgery, you see it's called oculofacial plastic surgery. When I started talking of ophthalmic and facial plastic surgery, and my business card said this about a decade ago, people would laugh. Today, it's really interesting that everyone's trying to rebrand themselves into facial aesthetics and oculofacial plastic surgery. So I feel vindicated all over again. ASOPRIS website is beginning to say your eyes, your face, and our passion. And the your face has actually come in only in the last 5 years. It used to be your eyes and other stuff. But your eyes, your face, and our passion is what is demonstrating the fact that there's a change which is happening. And interestingly, the website homepage says no one knows your eyes and face like an ASOPRIS surgeon. So that's the interesting part which is moving forward. It's also talking about the exclusivity of the health and the beauty of the eyes and the face, because the eyes reside in the face, and ultimately you need to be able to treat everything holistically. Now, if you look, even the mission, they put the face first before they put the orbital eyelids and the lacrimal system, which again points to a change which is occurring all over the world and globally. And this is in 2019. So you can see that even at 50 years, and now it's 55, so you can see that those changes had begun to occur. It's also important to demarcate between plastic and cosmetic surgery, because in India especially, there will be general plastic surgeons who say that a cosmetic surgeon should not do X, Y, and Z. But you need to understand that cosmetic surgery is very different from plastic surgery. When I do a rhinoplasty and I'm trying to raise the nose by only a millimeter, it's not the same as functionally correcting the nose sometimes. So the type of patient you'll do a blepharoplasty in or a 1 millimeter ptosis in is not the same patient as the one who has a very big ptosis or who's got big eyelid bags, right? So you need to understand that people are different. And the market wants that. If you look at the cosmetic procedures in the US and you look at all the statistics, you can see that these are procedures which are continuously expanding. Even if you were treating only non-surgical procedures, 89% of those amount of patients could have been treated by you. So that's an important part to realize that. And if you look at the number of cosmetic, minimally invasive, as well as other types of procedures, you can say Botox is rising all the time, but so are other procedures. And that's making all the difference, right? Now, the other aspect is medical tourism trends in India. I don't know if everyone in this room is aware, but India is the 5th largest medical tourism destination. And being the 5th largest medical tourism destination in the world, it is a great time to develop cosmetic surgery, because in major parts of the world, on the western side of the planet, cosmetic surgery is not covered by insurance. And so when I do my deep plane facelift and I'm American board certified and I charge 1 less than the American surgeon or one of my colleagues who's based in the US, there's enough reason for people to travel to India and get treated. Interestingly, this sort of dichotomy exists not only in oculofacial plastic surgery, it also occurs in the MCH plastic surgeons. This is an editorial which was published in 2012 by the then president of the Association of Plastic Surgeons of India, where he talks about how MCH plastic surgery residency may not really train people in cosmetic surgery. So the point that I'm trying to make is, if no one's trained at residency level, why are we not doing enough fellowships, and why are our fellowships not training people in doing this better? Now, if you look at the American Academy of Cosmetic Surgery, actually, the differentiation started to occur in 1979 when the American Academy of Cosmetic Surgery actually separated itself out from plastic surgery and developed multiple boards, one of which was the ESOPRIS, but there were also other boards which were affiliated to the AACS. So if you look at the major specialties doing cosmetic surgery in the US, it's either ENT, oromaxillofacial surgeons, oculofacial, and dermatology. And AACS also encourages all of its members to be either ABCS, which is the American Board of Cosmetic Surgery, and the American Board of Facial Cosmetic Surgery, to actually start training and becoming members of that and becoming diplomates of that. Increasing super specialization has also meant that now there are different boards, both for the body as well as the facial cosmetic surgery. I'm running out of time, but essentially, if you look at the American Board of Facial Cosmetic Surgery, of which I am a part, you see that the surgical log requirements are extremely detailed. They are all about cosmetic surgery. And if you look at the number of oculoplastic surgeons here, approximately about 15% of the ABFCS diplomates currently all over the world come from an ophthalmology or oculofacial background. And that's the major change. These things will continue to develop. People will continue to ask who can inject Botox, who can inject fillers, who is the one who is really supposed to do all of these things. But I tell you just one thing, at the end of the day, we are here in it for our patients. And if you want to make holistic changes on faces of patients, it's important for us to treat the face as a whole. And that's why I think this course is important. And treating people in facial cosmetic surgery is something that we all need to learn to do. I thank you once again for your kind attention and a very patient hearing.
Thank you very much, Dr. Debraj. One quick question that I'd like to hear your recommendation for the young ophthalmologist, plastic surgeon. Do you recommend the people who want to learn cosmetic surgery after the functional, getting good at functional procedure, or simultaneously?
That's a great question, Masashi. We have a university accredited fellowship which we run here on facial cosmetic surgery. Who comes in for that fellowship? Maxillofacial surgeons, general surgeons, MCH plastic surgeons, oculofacial plastic surgeons, all of them come in. Some of them come in after they've trained in functional oculoplasty. But I have also trained people who've not trained in functional oculoplasty, have come in directly from their residency because they want to learn only the cosmetic part of stuff. The person who wants to learn a cosmetic brow lift may not necessarily want to learn how to do a DCR. Okay. So it depends on what we want to learn and what we want to be good at, in my opinion.
Okay, thank you very much.